premenstrual dysphoric disorder is a combination of symptoms which are both physical and in particular psychological that affects a woman's life in a significant way. There are quite strict criteria when it comes to premenstrual dysphoric disorder, so PMDD, that the American Psychiatric Association has laid down, which includes almost 11 sort of psychological symptoms, which includes irritability, mood swings, food cravings, binge eating, concentration lack, fatigue, insomnia, headaches, anxiety and panic attacks, and depression, and even suicidal thoughts. But along with it, there are physical symptoms as well, and these need to be strictly happen in the premenstrual phase, which is a week or two before the period, and should cyclically happen almost during every single period or cycle, and should be enough and significant to affect the woman's life. As I said, in the UK, we call it severe premenstrual syndrome as opposed to PMDD, but that is a term that is now universally used generally. PMS is premenstrual syndrome. It consists of a combination or a variety of symptoms that are both physical and mental that happens in the premenstrual phase, so a week or two before the periods, persistently, consistently for most of their cycles, and affects a woman's life in general. PMDD, in general, as I said, not strictly used in the UK, but the corresponding term could be severe PMS, is a small minority of women, thankfully, out of the women who have premenstrual syndrome, where the symptoms are severe enough to affect their life in general and their social and all other circumstances because of the way it affects them negatively. So PMDD is probably corresponds to a severe form of premenstrual syndrome. Premenstrual symptoms and syndrome in general is about 40% of women who have menstruation. So PMS is not known before puberty, after menopause, and during pregnancy. So it obviously has something to do with the hormones and probably a hormonal fluctuation, and more specifically probably due to the progesterone and the effect of progesterone and possibly estrogen on the central neurotransmitters. So neurotransmitters, nerve transmitters in the brain, particularly serotonin and GABA. Now, 40% of women, as I said, who have menstruation probably suffers from some sort of premenstrual symptoms, but PMDD or severe premenstrual syndrome is somewhat rare. About 5 to 8% specifically in the UK, probably up to 10% suffers from PMDD. The symptoms, as I said, are both physical and psychological. Physical symptoms generally include headaches, insomnia, nausea sometimes, bloating, breast tenderness, swelling of the legs due to water retention, and a general body ache, malaise. The psychological symptoms, as I had said for PMDD before, include irritability, mood swings, lack of concentration, anxiety, and most of it. Obviously, it varies in severity, but it's a combination. It's quite often a combination of symptoms that happens. And yes, therefore, there is a whole plethora or a whole gamut of symptoms that quite often leads to this. Yes, I mean, menstrual disorders can be varied. Menstrual disorders could include just the amount of menstruation one is having, the frequency of menstruation one is having, pain during menstruation. But PMS is somewhat linked, but quite distinct in a way. Symptoms, the physical symptoms can, of course, overlap. Even in any normal premenstrual phase, any woman would have some of these symptoms. But even with certain conditions like endometriosis, adenomyosis, fibroids, pelvic infection, some of these symptoms can be increased. Similarly, many other conditions, other psychological conditions can also have an overlap. And therefore, it's important to maintain that criteria, as I had said before, that it has to be every single cycle or most of the cycles and on a regular basis. And therefore, that has specific issues with regards to the diagnosis as well. Ideally, because as I said, there is so much overlap with not only other gynecological conditions, but with many psychological and psychiatric conditions. The diagnosis has to be quite strict, and there's a subjectivity to the diagnosis at times. So ideally, it should be a prospective diagnosis and not a retrospective diagnosis where one may just come with certain symptoms, and as a clinician, I consider it to be PMDD, because that's more subjective. So what we normally is recommended by the Royal College of Obstetricians and Gynecologists in the UK is that we give the woman a chart, a PMS chart, and there are many charts, but one of them, for example, that is considered quite good is if one goes and looks at the website on the pms.org.uk, and there are many other good charts there, and one needs to fill that in for at least 2 cycles, 2 months, so as to see what symptoms one has, both physical and mental, as well as the timing of the symptoms. And then one needs to review that in the clinic to then make a proper diagnosis of PMS. Now, if that is difficult, despite all that, then of course, one may need more drastic action, which is giving a GnRH analog, which is an injection, or sometimes 3 injections, which what it does is it induces a menopause-like state temporarily, and that shuts down the normal hormones, and therefore the hormonal effect that presumably leads to the symptoms of PMS are excluded. And therefore, when one is going through that menopause-like state, because the hormonal fluctuation should not ideally happen, they should not have the symptoms of PMS. So if the PMS symptoms are alleviated when they have had this injection, we can diagnose that as PMS. This is particularly important if one has exhausted all other medical and other forms of treatment for PMS or PMDD, and it has not worked, and one goes for the last treatment option, which is a surgical option, where one may have a hysterectomy along with removal of the tubes and the ovaries to take away any hormonal fluctuation or hormonal effect. And if one has to go to that extent, then one ideally should always test it with a GnRH analog injection, as I said before embarking on that.